Kidney story time. So a few years ago, I was working in an acute medical unit, and I was handed over a patient when I came on for the night shift, whom I was told was heading towards palliation. Now, a consultant handed over this patient to me, saying that this patient had presented with diabetic ketoacidosis, DKA, but despite being on treatment for 24 hours, her bicarb level had remained low at 4. And for those of you who don't know about bicarb, so a normal bicarb is 23. Anything less means that you do not have enough bicarb or base in your blood, and your blood becomes acidic. So essentially the patient's blood is very acidic. Anyway, so the consultant said, we're going to palliate her. So I started my shift, and it was my first year as a renal registrar. And so I did what any renal registrar would do and calculate the anion gap. And it turned out to be a normal anion gap metabolic acidosis. And so what I did was that I stopped the sodium chloride overnight and replaced it with Hartmann's. That's all I did. And by the next morning, the bicarbonate had gone from 4 up to 9. So it more than doubled. And when the day team came on, I handed over this patient, and they decided to reverse the palliation for this patient. And this patient ended up going to the ward, and if I didn't remember wrongly, she did survive. So, moral of the story is, number 1, calculate your anion gap. Number 2, be very careful when you give sodium chloride. I'm probably going to do another post ranting about sodium chloride, but that will be for another day. And thirdly, I personally feel that a lot of the DKA and HHS protocols need to be updated, particularly the fluid regime. There is good reason why you give sodium chloride, particularly in patients with HHS, because you don't want the osmolarity to drop too quick. But even then, I think the protocol needs to be reviewed and updated. That's my own personal opinion. If there's any endocrinologist that's watching this video, feel free to weigh in here. I would love to hear your opinions.